Anecdotally, in this country, African American men are less likely to seek out preventive care than other demographic groups. And they also have higher rates of medical mistrust. Some of that has been discussed in the literature as being related to this horrific incident in our history of the Tuskegee syphilis experiment, which was carried out on African American men between 1932 and 1972. In 1972, a whistleblower took the story to the news, and it became public knowledge that this was going on, that there were men in the South that were being deceived, thought they were being treated by doctors, by public health officials, and in fact were just being experimented on, many of whom were dying. We used the sharp timing event in 1972 when it was revealed by a whistleblower that this was occurring and became common knowledge. We used that event along with demographic characteristics and geographic characteristics to identify that that disclosure event reduced healthcare utilization and increased medical mistrust, specifically among African American men. African American men live on average about 5 years less than their nearest neighbor, which would be a life expectancy neighbor, which is non-Hispanic white men. Some of these causes of death might surprise you. It's not due to, the gap is not explained by things like homicides or even HIV/AIDS, which disproportionately affect the African American community, but it's actually explained by more mundane, if you will, causes such as cardiovascular disease and cancer. And why that's interesting is because, again, many of those diseases can be cured, or at least the mortality risk can be displaced into the future if someone has access or avails themselves of primary or secondary prevention. There was about a third reduction in healthcare utilization and a pretty significant increase in mortality related to the disclosure event, as well as this increase in medical mistrust. It led me down the path of thinking, well, what could be done? We were able to construct a clinic, run a clinic out of Oakland, California, recruit African American men from the surrounding Alameda County, mainly from black barbershops, which are really comfortable, familiar gathering places where you can get a really broad cross-section of the African American male community. And then we were able to randomly assign them to either African American male doctors or white or Asian doctors. And after providing them with free transportation, providing them with free services, so kind of getting rid of all the constraints in terms of transportation or in terms of cost, we were able to kind of narrowly focus on this question of would concordance between the race of the doctor and the race of the patient, would that actually make a difference and improve the take-up of medical care among this particular group? And we found that it did. We found that it mattered quite a bit.